It's time now for your local hospital on the town. Brought to you by Sierra Nevada Memorial Hospital, Dignity Health. And now here's your host, Dr. Brian Evans.
Well, thank you for joining us and welcome to your local hospital on the town. My name is Dr. Brian Evans. I'm the president and CEO of Sierra Nevada Memorial Hospital. And today I am very fortunate to be joined by Dr. David Campbell, who is the medical director and oncologist at the Dignity Health Sierra Nevada Memorial Hospital Cancer Center. Thank you very much for joining us, Dr. Campbell.
Thank you for inviting me, Brian.
Appreciate it, yeah, and welcome to the show. So I have a bunch of different things that I really want to cover with you today and kind of talk about what's new and what's going on. And I certainly want to get to anything you want to bring up during the course of this. But there's always a lot of change going on in the world of oncology and in cancer care. Tell me, when did you come to this community? When did you get involved in the Cancer Center? Tell me about the sort of reasons for you joining this community in this capacity.
Well, I grew up in part here, sort of. I grew up in part over in Meadow Vista, which is near Colfax. Lived there a good portion of my childhood, and then from there moved to other California cities. Ultimately went to high school in Livermore. And then after medical school and residency and then fellowship, I learned of an oncologist that was here that was looking for a business partner, and I jumped at the chance.
And I think I know this guy.
I think you do.
Yeah. So who was that?
So that was Bill Newsom, who came here in, I think, 81 and had lived here until his practice outgrew a one-doctor practice. And so at that point, he was looking for another oncologist, and I fit the bill. So I came here in 1994.
Okay. Well, we're glad you did. And Dr. Newsom, obviously a big part of the community for many years. I still remember calling him in the middle of the night with questions and waking him up from a deep sleep, and he was always very kind about that. So if you're listening, Bill, we appreciate that. So that was a while back, and the Cancer Center has really gone through some changes over the years. What is the most notable change that you've seen in the Cancer Center here at Sierra Nevada that you've been through, and tell me how this Cancer Center really functions now?
Well, we now really have a cancer program that wasn't existing when I first arrived. When I first arrived, for example, we did not yet have radiation oncology. Mm-hmm. That came about 6-8 months later, mm-hmm. and the cancer program didn't exist as an entity until radiation oncology arrived. And then after that, Bill and I moved into our present location within the hospital building. Mm-hmm. And from there, it grew into more of a program in which we had social workers and nutritionists and nurse navigators, and the list goes on. And we now have 2 radiation oncologists and 2 full-time medical oncologists. Bill has retired, and we've recruited Jamie Hung. Mm-hmm. And the radiation oncologists have taken a leadership role as well in our cancer program. And it's shifted a bit as well in terms of how we treat patients. Mm-hmm. For example, the shift has turned away from chemotherapy in large part and now toward targeted and immunotherapies mm-hmm. that are, of course, more effective and less toxic for the most part.
Okay. So you mentioned radiation oncology, and I'm not sure that folks know really what the difference is between radiation oncology and medical oncology. So can you, and you have doctors that do those things here, radiation and medical oncology here. So what's the difference, and what should patients know about that?
Right. So we have medical oncologists, and as the name implies, we are medical doctors, mm-hmm. and so we tend to treat patients with medical therapies. Mm-hmm. So medicines or other therapies that are involving treatment that get into the system and treat cancers. And the radiation oncologists are physicians who treat patients with X-ray therapies. So as you can imagine, getting an X-ray, maybe a chest X-ray, except that X-rays are delivered in high doses at a specific site that is desired. So it's not a global whole body treatment. The body could not withstand that much X-ray all at once. And so we treat cancers with X-rays directed specifically toward one site of the body or another, depending on where the cancer is.
Got it. Okay. So if you're evaluating a patient and you feel that they maybe are a candidate for radiation therapy and they're going to benefit from that, then you might send them over to the radiation oncologist who works just down the hall from you here at the Cancer Center, and they can get set up for that.
That's right. In fact, it's very nice the way we're situated, because radiation oncologists here in our cancer program are just within almost a stone throw of my office. So if I need a radiation oncologist, I just step out of my office, and 30 or 40 steps later, I'm in their office and knocking on their door, and they can pull up the records as I'm speaking about the patient and give me a kind of a curbside analysis on whether the patient would be appropriate for a radiation oncology consultation.
Mm-hmm. So it's unusual for a community hospital of this size to have all of these comprehensive services and this whole team that you talked about. It's a whole team of people taking care of patients that have cancer. How have we been able to be so fortunate to build this thing and build such a comprehensive approach, get a radiation oncology setup going here? Is it the community support, or who's responsible for that?
Yeah, well, it is. You are correct. It's a bit unusual. I've gotten to get used to it. So to me, I think it's been my way of life for a couple decades now.
Yeah.
And this is all thanks to my predecessor, Bill Newsom. Bill had a vision, and he was the one that got this going in large part, and then got talented people involved to help take their own little sections and run with it, and then Bill could take his medical oncologist section and run with that. He was the medical director of our cancer program for a long time until he retired, and then I became the medical director after that. But it was Bill's vision.
Well, it's quite a vision. It's quite a legacy for Dr. Newsom and others that have been involved in this, and we certainly appreciate his efforts and yours in really building what's a world-class cancer center for a community of this size. It's extraordinary. I want to go back to something you said about how cancer care has really shifted, and you mentioned that chemotherapy was really the mainstay of cancer care for many years, and now there seems to be a shift towards what you called more targeted approaches to cancer. Can you go into a little bit more detail what that means? What does that mean, more targeted as opposed to chemotherapy? Why would we want to get away from chemotherapy and more towards this other thing?
So chemotherapy is a term that I believe should be reserved for specific treatments that are toxic to the body, the normal cells, and also toxic to cancer cells. So these are poisons. These are medicines that kill cancer, but also kill us in high doses. And so I realize that we now have shifted into an era where medicines are prescribed that are not necessarily toxic to normal cells. And I think that we should start thinking of these as being different. They are specifically not chemotherapy. They are targeted, which means there's a target within the cancer cell that doesn't exist in normal cells. And if you can target that whatever it is in a cancer cell, then that's a targeted therapy that leaves normal cells relatively intact. And so we have a variety of targeted treatments these days that we're using, and as targeted therapies become more effective and less toxic, we can oust chemotherapy and replace them with targeted therapies. Immunotherapy is a different way of looking at how we can treat cancer, and that is to fool the body into detecting the cancer cell with its own immune system that in a sense may be targeted, but it uses the immune system to effectively kill the cancer and not recognize the normal cells as being foreign. So that's kind of where we're moving on with therapies, more the immunotherapy and targeted agents. And there are other ways as well, but those are the most common that we're using now that's changed our view in terms of treatment. Many people will speak of these therapies as chemotherapy. For example, I have patients coming in all the time saying, I'm taking this chemotherapy pill, and I try to encourage people not to use those terms unless they're actually taking chemotherapy. I think it makes people think of treatment differently when they're taking chemotherapy versus a targeted agent.
I think that's probably true, and we're going to take a short break, but I want to get into what it means for a patient on their side of the coin here when they're on one versus the other right after this. Welcome back to your local hospital on the town. I'm Dr. Brian Evans, the president and CEO of Sierra Nevada Memorial Hospital. Again, I'm joined by Dr. David Campbell, who's the medical director and oncologist at the Cancer Center here at the hospital. Thanks for being with us, Dr. Campbell.
Thank you, Brian. We
were talking a little bit about the difference in ways that we're treating cancer these days with chemotherapy being kind of the older, more, the original way that cancer was treated, and now getting into more specific therapies. You talked about immunotherapy, you talked about biologics. And from a patient's point of view, how does it feel different to them? You talked about chemotherapy being literally a poison, essentially, that sometimes people have to take, but it's extremely harmful to our bodies. So when you have these conversations with patients, how do you explain that, and what are they going through that's different now?
The mechanism of action of these medicines is quite complex, many times more complex than I can fully comprehend, but I get the gist of how they work, and when that occurs, then I think that I can understand the gist of the toxicities as well, and that's what I try to explain to the patients, at least in general terms, how the treatments work, how this is different than other older and maybe some newer innovative therapies that are not yet available, but we pursue in terms of speaking with the patient, the specific mechanism of action and how that relates to the toxicities of the treatments that are available. And so if a person's taking a targeted agent, they might expect specific side effects that are not related to chemotherapy. For example, people typically think of chemotherapy as causing things like hair loss, and most of our targeted agents don't do that. So people don't feel like they look like a cancer patient, so to speak.
So it's really about side effects. When you're talking about toxicities, you're talking about side effects for patients. And typically non-medical folks that have cancer are going to be worried about losing their hair. They're going to be worried about having nausea and vomiting and diarrhea, things like that. And I've actually had cancer patients tell me that it's almost like they're trying to survive their chemotherapy almost more than they're trying to survive their cancer, and it's almost a battle between the two. So with the biologics and these more targeted, these more specific therapies, it's less side effects and it's more tolerable generally, it sounds like.
That's right. And so when a patient takes these medicines and they're trying to treat a cancer, whether it's curable or not, they're really trying to decide whether the toxicities of the treatment is worth the benefit. And so when you're taking a medicine that's highly toxic, then the pros may not outweigh the cons. And so many people choose not to take the treatments when they're pretty toxic, and yet now that we have less toxic treatments available, then more people are able to comfortably pursue treatment and complete their therapies and have the benefit of the therapy without as much toxicity.
Okay. So Dr. Campbell, the science of this, of cancer care, of these different, very sophisticated medications, it's really complicated. And so most patients that come to you, I suspect, don't have a science background, and they are extremely nervous or scared about what they're going through and what they're about to go through. How do you sort of break it down for them in a way that they can understand and deal with some of the emotions around this?
I do the best I can. In other words, all day I talk to patients, and all day I talk to physicians as well. Physicians have a different level of understanding of the body and medication mechanisms of action, and so we really do have to shift how we talk to patients, and it's not the same as we talk to other physicians. So if I do my job right, I speak with patients at a level that's not down necessarily, but different. And so I'm not trying to dummy it down, so to speak. I'm trying to change it so that it's more understandable for a person who doesn't have a science background. And so that's how I try to get patients to understand what I'm trying to choose to propose to them as opposed to a physician where I might be able to shorten my discussion a bit and say it in fewer words, and they would understand it on a different level.
One of the things we talked about before the break is this very collaborative approach to cancer care that we can now offer here at Sierra Nevada. So, it's not just physicians that are involved in taking care of patients, it's social workers and nurse navigators and others. Is a lot of that there to provide kind of an emotional support to the patients as they're going through something difficult?
Not really. We have a real team, and one team member isn't more or less important than another team member. It takes the whole team to make the program work well. For example, if the nurse navigator doesn't do her or his job correctly, then the patient isn't navigated, so to speak, to the different parts of the team members in the timely fashion that is required for best treatment. So, if you have one weak link in the group, then the whole thing falls apart. So you really have to have a qualified and talented group of team members in order to have the patient get through the treatment in the best way possible.
Okay, and there is a collaborative meeting that happens here at the hospital called Tumor Board. What is Tumor Board? How does that work? Who comes to that? What's that all about?
So this also, let me go back to Bill Newsom, was Bill's vision on how we run a tumor board. He recognized that the importance of a team approach, and our tumor board or cancer care conference is a once a week, 1 hour meeting in which we present patients anonymously for a collaborative discussion with all the team members. So I'm generally the moderator of that meeting, and I walk around the room, or I stand and point around the room for asking for discussions from the team members to get the best collaborative opinions on how best this person could be treated. And we have radiation oncology, pathology, radiology, medical oncology, nutrition, medical social worker. We have some integrative medicine practitioners, nurses, nurse practitioners, palliative care physicians, surgery. The list goes on, and those are that's not even a complete list, but that's a partial list of our team that we use to approach people with a variety of different cancers.
So it's really the old adage that 2 heads is better than 1, but maybe in this case, a couple dozen heads is better than 1. So you can really get everybody's opinions and sort out what is the best approach for patients in their sort of battle against cancer. So it's really not just a meeting where you guys get together and eat donuts and watch the news or anything like that. That's the rumor.
Donuts help.
The donuts help, yeah. So we don't want to cut those up.
Our nutritionist doesn't feel too good about that part of it, though.
I bet. Okay, we're going to take another quick break, and we'll be back after this. All right, welcome back to your local hospital on the town. I'm Dr. Brian Evans, President and CEO of Sierra Nevada Memorial Hospital. We're talking about cancer care with Dr. David Campbell, the medical director of the Cancer Center here at the hospital. So, Dr. Campbell, we're talking about how collaborative cancer care is, and it maybe differs in some ways than other specialties in that there's so many experts and people that need to be involved in the care of a patient with, a complex cancer situation. You talked about Tumor Board right here at the hospital. But there's also kind of a regional network here that involves our sister hospitals and others down in the Sacramento area. Tell me about that. How does that network work, and how does that add value to our patients here locally?
Thanks for bringing that up, Brian. That's a real important collaboration that we have. As you know, we're a small community hospital. We just can't have all the specialties here. We can't support specialties such as a neurosurgeon and multiple of the same specialties. We have one, for example, we have one infectious disease specialist, we have one pulmonologists, and some specialties we just don't have. So we do have a close connection with these specialties at our sister hospital that we use somewhat as a tertiary care facility to refer patients for a higher level of care when needed. For example, if a person needs lung cancer surgery, we have qualified lung cancer surgery at our sister hospitals in Sacramento. Most commonly, we use the hospital in Carmichael at Mercy San Juan, and they have other specialties as well. So it's a real important close collaboration. In addition, they also have access to our CAT scans and lab reports and clinic notes. They can look right there in their own hospital at the x-rays that were taken here in our hospital, and actually we can call them up and I can talk to them on the phone and say, can you look this patient up and tell me if it's appropriate referral for you? And within 5 minutes they'll tell me whether or not this patient should be referred to their office for whatever specialty I'm looking at.
So I think that's interesting for patients to know, and it's reassuring for patients to know that if they have a complicated cancer or something unusual or anything like that, they can still come here, and then you're going to be connected to a variety of other specialists. The patient or the family doesn't have to, go through the phone book and figure out where to go. You guys have all those contacts and access.
Yeah, it's our best interest. It's in our best interest to treat the patient appropriately. So we don't want to send a patient to a specialist that we wouldn't go to ourselves.
Right.
And when I mentioned we have quality physicians at those hospitals, I would use them myself. And so that, I think, has matched the vision and the efforts from Dignity Health to bring quality physicians to our hospitals that can treat the patients with the best care possible.
That's awesome. So, one of the other things that has come about recently that I'm just thrilled about is our new infusion center. And first of all, tell me about what an infusion center is and how you use that in the cancer center.
As we have mentioned, we prescribe medical therapies, many of which are intravenous and can't be taken by oral means. So an infusion center is where these treatments are administered. Previously, in the dark ages, and still to some degree, we prescribe chemotherapy, but now we're turning to immunotherapies and targeted agents, and yet they're still given intravenously. In the infusion center, nurses who are specialists in the administration of these medicines deliver them to the patients, and as you can imagine, there are frequently more than one patient in the infusion center at a time. In fact, there may be 10, 15, 20 patients at one time, and we need the facilities to treat them in a comfortable and sort of semi-private place. Previously to this, we had a very small infusion center, and people were crowded in, and the ability to treat them has now been expanded to a larger and nicer facility that we have called our infusion center. And it's beautiful. Patients love it.
It really is beautiful. I have to say, I've gone on, taken folks on tours into the infusion center. It has an incredible view out the south side of the hospital. You can really see quite a long ways, and it's a very comfortable place for people to be. So I want to thank you for your involvement in that, as well as anyone listening who helped contribute to this renovation and this project, because it was, again, another one of these examples of a collaboration between the hospital and the community. The community helped make this possible through their generosity and their vision. So really is a great asset to the community. And I'm glad you mentioned the nursing staff, because it's not just about hooking somebody up to an IV and letting the medicine run. People that are getting these medications are being monitored very carefully, and the nurses are right there, and it's a safe environment for them to receive these medications and watch out for side effects and that kind of thing while they're in that comfortable setting. So it's very special. Let me ask you this, Dr. Campbell. dealing with cancer, dealing with complicated patients, it's a stressful job. I think most people would have a difficult time imagining dealing with these kinds of very, very serious issues on a day-to-day basis. How do you deal with that stress? How do you manage that? How do you blow off steam? I do know one of your hobbies involves race car driving, so maybe you could tell us about that.
Well, when I see a patient with a cancer, it's easiest if I'm honest with the patient. So I don't want to beat around the bush. I don't want to make things a bit rosier than they are. I just tell them the way it is. It's completely an upfront, honest discussion. And I think patients appreciate that. It's the unknown that sometimes is the hardest for patients. Mm-hmm. For me, if I do my job right, it's not stressful. Of course it's stressful when patients do poorly, but if I still do my job correctly, I can comfortably go home and feel that I've done the best I could for that patient, and the patient's got the best care possible that could have been provided anywhere. So that helps me feel more comfortable with my stress and the job that I do. Sometimes things work out well, and of course sometimes people with cancer don't survive, but it's something I've learned to live with. And you mentioned race car driving. Yes, I do have a Miata that I take out and run time trials. I love it. It's something I do with one of my other cancer oncologists. He's a radiation oncologist, Dick Evans, and he and I try to get out about 5 or 6 weekends a year and so-called blow off steam.
Well, I remember being with you on one of those weekends a few years ago where you put me in the passenger seat of that Mazda, and I will never forget it. I think my heart is still pounding after that drive. It was terrifying, but a very exhilarating experience. Well, Dr. Campbell, I want to thank you for being here today, and I want to thank you especially for taking care of our community, taking fantastic care of patients here at the Cancer Centers here at Nevada Memorial Hospital. It really is a pleasure to work with you, and I'm proud to be able to call you a colleague. So thank you for being here today.
Thank you for inviting me.
All right.
This has been Your Local Hospital on the Town, brought to you by Sierra Nevada Memorial Hospital Dignity Health. Listen to Fourth Monday of every month to learn more about your local hospital.